Well, it is my pleasure to introduce to you Professor Andrew Day. Andrew is one of our own. He was born in Christchurch, trained in Otago Medical School. He then went to Canada, Toronto, and trained there. He went to the University of New South Wales and trained there, and came back to Christchurch in 2009. And in 2010, he became head of the department and professor of gastroenterology and paediatrics in Christchurch. He is the only person holding that position on the South Island. He looks after about 100 children from Nelson down to, I think it is Nelson, down to Bluff. So he has literally wide experience of the scene in Christchurch. Andrew, I'm terribly grateful for your willingness to accept our invitation to come today. I now pass to you the microphone, and the floor is yours, sir. Would you please welcome Professor.
Thank you very much for the invitation to come, Brian, and thank you very much for everyone joining us this afternoon. I'm going to talk a little bit about inflammatory bowel disease in children, infants, adolescents and children. I'm going to tell a little story first about Jane. Then we're going to talk about some basics about inflammatory bowel disease, some particular paediatric aspects. Talk a little bit about the approach and management to IBD in children and adolescents, and then talk about some of the key things in terms of growth and nutrition, which are one of the things that kids do a lot of. Most of us here have finished our growing, but kids need to focus on that. So first of all, we're just going to go back, and I'm not a very good art historian, but this is a picture of Madonna and Child from many centuries ago, and this was how Madonna and Child was portrayed for a little while by the artists at that time. And just to pose the question to you, are children little adults? Well, clearly this artist thought that they were. 100 years later, this was another Madonna and Child, and this is how children should be portrayed. So they're not just little adults, they're very different beings, different dimensions, different sizes, and that goes for general babies, as well as inflammatory bowel disease, as well as Crohn's and colitis. So Jane, so this little girl, age 3, presented in Christchurch about 6 months after the big earthquakes, and she'd had 9 months of some watery loose motions, and the family and the GP had attributed that to the earthquake on going down to the bathroom at the side of the street and so on. 3 weeks of increased diarrhoea, getting up at night many times a day, some blood and some mucus, lots of cramps, off food, becoming lethargic, getting a sore mouth, complaining of a sore mouth, and not gaining weight for some weeks as well. In the background, Jane had been born at the right time, had been breastfed for a few weeks. She had one elder sibling. There's a family history of the father's grandmother having had Crohn's disease many moons prior, and the father's mother had a long history of gut symptoms as well, but no specific diagnosis. There was a bit of a difference between Jane's weight and height, reflecting that she hadn't gained weight for some time. She was pale and quiet. She had some mouth ulcers, as we can see on the picture here. But the rest of the examination was pretty unremarkable. She had a whole series of blood tests, and many of you may have had similar blood tests, but she was anemic, her platelets were high, her ESR and her CRP, so markers of inflammation, were high, and her albumin was just coming down a little bit, so it's a negative marker of inflammation, if you like. She had some stool tests and didn't have any infections, but lots and lots of white cells. So she proceeded to have some scopes, and she had some redness in the surface of her stomach. This doesn't project very well with the light, I'm afraid, but this is showing lots of big serpiginous ulcers that were present in her colon, and then some little aphthoid ulcers around the more proximal part, including the end of the small bowel as well. So she had ileocolonic Crohn's disease involving the small and the large bowel, with also some upper gut involving the stomach as well. And she proceeded to have treatment and is doing very well at this time. So what is inflammatory bowel disease? And I imagine that many of you in the audience will know the answer to some of these questions, so to speak. But just to go over, so that's a relapsing, remitting, a coming and going condition with chronic, lifelong inflammation in the gut. This has been around for a long time. So this chap, who lived in Ephesus, which is on the west coast of Turkey. He was actually a gynecologist, but he also dabbled in gastrointestinal problems, and he described a diarrheal illness in AD 130 that sounds very much like Crohn's disease. And obviously his name goes along with someone with inflammatory bowel disease as well. It's probably not pronounced Soranus, but Alfred the Great was also thought to have inflammatory bowel disease. So this was in 1850 AD in the UK, and he had long-term gastrointestinal illness, and it was attributed to witchcraft. It was also attributed to his extramarital affairs and other bits and pieces. But there's certainly a number of things to suggest that he had Crohn's disease as well. And then last century, we have Burrell Crone himself. And he and his colleagues at the Mount Sinai Hospital in New York characterized a group of young adults, young men, that had inflammation affecting the end of the small bowel. And they called it regional ileitis, but subsequently it's become to be known as Crohn's disease or Crohn disease. But it could well have been Ginsberg's disease or Oppenheimer's disease, as you can see from the other names in that group. Shortly afterwards, it was also described in Poland, and they call it something different. They don't call it Crohn disease, but they have a different name for it, and that reflecting who was involved in describing it at that point. So Crohn's disease and ulcerative colitis affect the gut. And this is just a picture of the esophagus coming down to the stomach, the small bowel. I don't usually have a flower at the end of my small bowel, but some of you may do. And then the large bowel coming around. What does this look like normally? Before we think about what it looks like in the context of inflammatory bowel disease, this is a picture looking at the stomach, seeing the folds of the stomach going down towards the exit of the stomach. Here's some pictures of the large bowel. This is the sigmoid or the descending colon down on this side on the left. This is what it looks like normally. You can see the little blood vessels. It's sort of glistening and shiny. This is around a bit further. And now for those that can see, there's a dark shadow here, and that's the liver. So it's sitting just up on this side where the large bowel goes. And this is the large bowel coming up on the right side. And just in here, behind this fold, is where the small bowel's joining into the large bowel. And this is a picture of the appendix. So down here in the right lower side. And this little fold here is where the appendix is. Some of you may not have your appendix, but some probably still do. So what does this look like in the context of Crohn's disease? So Crohn's disease, anywhere from the mouth all the way through those different parts to the bottom end. This is some pictures of ulcers inside the mouth. And I think Brian's going to talk to you a little bit later about some of the other oral manifestations of Crohn's disease too, in terms of being more and more recognised. Can involve the end part of the small bowel. This is an X-ray test. This is the cecum where the appendix is, and this is the small bowel here coming down to join. And in this person, it's quite narrowed because of the inflammation and the thickening of the wall at that point. So that's one common area. Ulceration on the surface is a very common manifestation. This is a normal appearance again on this side. And that white stuff is exudate or stuff sitting on top of the ulcers. And you can see it looks red and raw and sore for that person. Here's another picture of some ulcers coming along and another one on the far side. One of the features of Crohn's particularly is what's called skip lesions. So there can be normal bowel ulcers, normal bowel ulcers. And here's one sort of presentation of that. We've got normal bowel, we've got this area of ulceration just in the middle with normal things all around it. And that's very common for Crohn's disease. Here's some other pictures also of different ulcers and in locations through the bowel. Ulcerative colitis affecting the large bowel. So the large bowel coming across, down through the pelvis and out. It might involve just that very lower part, so-called proctitis. So the last 6 centimetres or the last 10 centimetres, the last little bit. It might involve most of that left side, indicated with the circles there. Or all of the colon, so-called pancolitis, so involving the whole length of the colon. And this might be some pictures of what it could look like. So granular, lots of ulcers, you've lost that normal glistening surface with the blood vessels. It's very fragile, it'll bleed easily. Here's some other pictures, again with some exudate or pus sitting on ulcers from some children with ulcerative colitis. We have Crohn's disease on one side, we have ulcerative colitis on the other side, and they're the two major types of inflammatory bowel disease. But for some people, we know it's inflammatory bowel disease, but we can't decide which side of the fence it's going to be. And that's the best name for that nowadays is IBD unclassified, or IBDU. For some people, it might look a little bit like this. So this person's got an inflamed semicolon, but it might not happen very often. So what causes this inflammatory bowel disease thing? Crohn's disease and ulcerative colitis, how can they develop? The best way to understand that is that it's a combination of things. So genes are very, very important. So having the right combination of genes then sets up for the next part of the equation. And that's bacteria, things that flow through the gut or things that live in the gut, and then the immune response. So the combination of those three things is really important. So if you've got the combination of the genes, and almost all the genes that have been described that link in with inflammatory bowel disease control how the surface of the bowel defends itself from things that are going past it. And we'll have an illustration of that in a moment. So if you have the genes that have gone wrong, then the immune system becomes out of control, responding to what's going past it, and then dysregulated or having a life of its own. And that's another way to look at things. So it's the bacteria, the epithelium or the lining cells, and the immune cells, and how they play together, all important in terms of the development of inflammatory bowel disease, whether it's Crohn's or ulcerative colitis. There's over 160 odd genes that are now described, many of those linking in with Crohn's disease, some just with ulcerative colitis, and some with both. As I said, almost all of the genes relate to how the body defends itself. This is just an example of some of those. This is the chromosomes that those genes are found on. You can see that there's chromosome 1 to 18, lots of genes scattered across our DNA that have been implicated in inflammatory bowel disease. One of the most important of those is the NOD2 gene. And that's probably present in 30% of Europeans with inflammatory bowel disease, or particularly Crohn's disease. It's something that's not a risk factor in other populations like the Japanese. And this gene encodes for a protein. In this cartoon, it's this little protein here. And this protein is like it's a receptor inside the cells. Explaining the rest of the cartoon. So this is the lining cells of the gut, this is the bacteria floating through the bowel, and this is all inside. And this little protein here recognizes a breakdown product of bacteria called muramyl dipeptide, which gets through the gut, inside the cell, recognized by that protein, and that leads to a whole cascade of different things happening inside the cell that trigger inflammation. So this is one of the ways the body defends itself. When people have a mutation of this gene, this process goes astray. So instead of having a nice leisurely stroll through this cascade, it's exaggerated and things get sped up and it leads to more inflammation. So that ties together the bacteria, the gene, and how the inflammation responds, how the immune system responds, because this drives all those immune cells. One can think in terms of calling out an all alarms forecast at the fire station. It's not just the fire station, it's the ambulance and the army and the navy and the air force. Everyone's coming to fight the battle, and it's being driven by this sort of process. In children, there's a number of genes that have been associated to occur with very, very early onset inflammatory bowel disease. So this is two, TNF promoter and the IL-10 gene are linked with Crohn's disease or with colitis developing not just in childhood, but particularly in the first year or in the first 2 years. And there's now an international consortium that's looking at some of the taking this further in terms of trying to understand and looking at the genes in children that are diagnosed before the age of 6 years of age, in terms of trying to identify more genes that are involved with early onset inflammatory bowel disease. And these genetic patterns aren't related to disease in adults, they're just related to disease in children. So I've mentioned the bacteria, and as I've implied, the bacteria that all of us have play very important roles in the development of inflammatory bowel disease, and I'm just going to touch on that a little bit more. So the bugs that live in the gut, so this person has 100 trillion bugs in his gut, they're very central to health. We couldn't do without them. But they may also be contributing to problems that we have. There's thought to be 10 to the 13 bacterial cells that most of us have, equating to around about 1.5 kilograms of bacteria if we put them all up on the table. And there's 10 to the 12 cells that we have in our body. So there's 10 times more bacteria than there are cells within our body. There's a huge number of bugs that live within us. Each of us, depending on where we grew up and what we had to eat and how long we were breastfed and all other things that happen early in life, have, if you like, a fingerprint that's a little bit unique. We have slightly different balance of some bugs than others. And there's methods that we can do to look at the bacterial profile, look at the DNA within the genes, and if you like, fingerprint what your stool is and how it differs from mine. And people have done that looking in people in Africa compared to Scotland and showing very different patterns in terms of the bugs that grow there as a consequence. Lots of things during modern life, particularly in the Western civilization, have likely changed the patterns of the flora, and this is just some of those. So clean water means that we transmit bugs less from person to person. Changing patterns of delivery in terms of less vaginal delivery, more caesarean section. Change the patterns in terms of how infants gain those bugs early on. Antibiotics use, breastfeeding patterns, again change how the flora develops. Changes in family size, antibacterial soaps, on the ads many times every day probably in terms of antibacterial this or whatever. But all of these factors may well be influencing, and certainly are influencing in some of the cases, how the flora develops, how those bacteria develop early on, and that can influence how the gut develops and how the gut responds to things that it might come into contact with later on. There's one manifestation of this is this sort of work, looking at pigs that grew up outside compared to pigs that grew up and were housed in a building. And they showed that pigs that grew up outside had much more friendly or helpful bacteria in their gut than those that would grow up inside. Not suggesting that we need to eat like pigs or live like pigs, but and this is part of the hygiene hypothesis that many of you may be aware of as well, that priming our immune system, the development of our immune system, it's really important to be exposed to those things early on, like little pigs playing around in the dirt. There's a number of bacteria that have been looked at in terms of, could this be the bug that causes inflammatory bowel disease? Could this be the bug that causes Crohn's disease? And this is a list of some of these. This guy at the top has been, many places around the world have been looking very closely at this organism. It's related closely to TB. It's transmitted probably very easily within milk that we drink. And many, and particularly in New Zealand, many of the deer, sheep, cattle can become infected with this bug, and it causes a condition called Johne's disease that has some similarities to Crohn's disease. But with this or any of these other bugs, nobody's been able to say that this is the bug that causes inflammatory bowel disease. We've been looking at the bugs that live in the mucus. So along the edge of the lining cells of the gut is a layer of mucus, and in this staining it's orange. and these little yellow guys that are counterstained are bacteria. So we've been looking at the bugs that live in the mucus because they're right next to the lining cells of the gut, and trying to understand, could these bugs be important in the development of Crohn's disease or indeed ulcerative colitis? This is what the bugs that we've been looking at look like. So they're like a little cigar shape. They've got a little tail at the end, and that little tail or flagellum helps them to move through the mucus, swimming through the mucus so they can get round down to the cell. And these bugs belong to the Campylobacter group, and they're called Campylobacter concisus. And this is what they do. This is the electron microscopy. This is the bugs here attacking, joining onto and invading into the lining cells of the gut. And we've shown that these bugs are present much, much more commonly in children at the time of diagnosis with Crohn's disease. There's some colleagues in Scotland who have been looking at adults with Crohn's disease and ulcerative colitis and showing the same sort of patterns. It's not that every child with Crohn's disease had it and children without Crohn's disease had, well, 0% had it, but it's much more common. And we've shown that it's very frequently present, that it attacks and invades, and it prompts those lining cells of the gut to mount a response, so mounting some inflammation. And at the moment we're not sure whether this is a major player or the major player, or whether it's just a contributing factor, but certainly it's there, and it certainly leads to a number of changes that could contribute to the development of inflammation in IBD, or perhaps the perpetuation of inflammation. But at the moment, there's no answers in terms of which bug's important, but this is certainly a strong candidate for being an important bug. So, which kids get inflammatory bowel disease? The answer is that it can be any time through childhood. I look after children in the first, up till they leave school, usually, and although it's most common in the second decade, particularly in the 12, 13, 14, 15, 16 age group, it can be any age. Boys tend to get inflammatory bowel disease a bit more than girls. In the adult age range, it's around the other way. Females tend to get more than males. This is some data from Australia showing the age at diagnosis. This is only of the first 14 years. And you can see as you get into the second decade, more and more and more children diagnosed at each age group going upwards. But right down to point 0. And there's this little peak at 3 and 4. So this is Jane at this point here. And many series that have looked at when children are diagnosed note this sort of double peak. A little peak here in the preschool age group, and then a much bigger peak in that first part of the second decade. If we were to look beyond this, at 15, 16, 17, 20, etc., we would find that that curve goes up. But this data is just focusing upon the first 1.5 decades. There's many studies showing that inflammatory bowel disease around the world has been accelerating, more and more common. This slide begins in the middle part of last century and shows that things were starting to increase at that point. If we were to continue this graph, that curve goes up and up in almost every place that it's been looked at. Even movie stars. Can anyone recognise this singer? I don't actually know any of her songs, but it's Anastasia. But so she's got a little scar down here from her Crohn's disease. So inflammatory bowel disease continuing to increase, particularly Crohn's disease, and more studies showing developing at a younger and younger age. This century has featured increasing rates of Crohn's disease and colitis, particularly colitis, in new countries. Taiwan, Japan, countries where IBD was thought never to exist. It certainly does, and it's becoming more and more common in those countries. Several Australasian studies show that we have rates of Crohn's disease that's as high as anywhere else in the world. Richard Geary, my colleague in Christchurch, looked in the Canterbury region and showed this rate of 16.5 per 100,000 per year, which at that point was the highest rate. And there's subsequently been a study from Victoria in Australia that shows even higher rates. So unfortunately, Australia and New Zealand are up there in terms of the first and second ranks, if you like, in terms of Crohn's disease. And furthermore, many studies showing increasing rates in children. This is 2 studies, both from Melbourne in Australia. This study looked at a 30-year period up to the turn of the century and showing that the rates of Crohn's disease in children in the first 2 decades had increased 10 times over that 30-year period. Another study looked at ulcerative colitis over 60 years, up till, this was published last year, and they showed again a 10-fold increase, but it was particularly since the turn of the century. So over the last decade, huge increase, 10 times more children being diagnosed each year than there were before. And this isn't unique to Melbourne and Victoria. And studies from many different places around the world have shown the same sort of pattern. So more and more children, more and more adolescents being diagnosed. So how might a child present? And this is just a little picture of somebody with a sore tummy, but they can present with losing appetite, fever, fatigue, tummy pain, weight loss, diarrhea, all sorts of things. And sometimes just not getting taller, sometimes just mouth ulcers or other oral changes. This is just an illustration of the range of symptoms. This is some 2 groups of children from Toronto in Canada. So about 400 children with Crohn's disease and 200 with ulcerative colitis, and looking at the patterns of symptoms. And the children with Crohn's disease, pain, diarrhea and weight loss were the main symptoms. Not in 100% of children, but many, many of those children. Whereas in those with ulcerative colitis, diarrhea and blood were the main symptoms. So bloody diarrhea. But you can see that it's not 100 versus 0 in these things. There's lots of crossover. So children can have lots of different symptoms. This group also looked at that same pattern in a different group of children. 78% had those classical symptoms: weight loss, diarrhea, tummy pain. But the other children presented in a whole lot of different ways. It might be presenting to the surgeons with short onset of tummy pain. And last July, so July 2011, I had 2 girls present. One had about 4 days of symptoms and one had probably 2 or 3 weeks of symptoms. Presented to the surgeons with tummy pain. Did they have appendicitis? And they both had quite nasty Crohn's disease. It might be presenting to the psychiatrists with, my child's not eating, my child's losing weight. Do they have anorexia nervosa? But they've got Crohn's disease. Or presenting to the hematologist with an iron deficiency. Or to the endocrinologist with, my child's not getting taller. What's wrong? Why aren't they growing? They may not have tummy symptoms. They may have lots of other symptoms. But it all equals in the end to Crohn's disease. So lots of different ways that children can present. When children presenting in different ways, that can mean that children may not get diagnosed and may not get picked up or thought about for some time. So this is some data from Australia. Almost 700 children, on average just over 12 years of age. 400 had Crohn's disease, and then some had ulcerative colitis and some had that sitting on the fence type of IBD. The children with Crohn's disease had a median of 26 weeks of symptoms before they were diagnosed, compared to the children with ulcerative colitis had 12 weeks. And if we think of the most common symptoms, clearly parents and GPs are recognising that bloody diarrhea isn't the thing that kids should be doing. Many of these kids have long periods of symptoms, and this is the median, and the range can extend out to many years, so 3 or 4 years on occasion. Furthermore, the time to diagnosis was inversely proportional to their age. So the very young children, those preschool children like Jane, had a much, much longer period of symptoms. And oftentimes I hear parents telling me that they've been to the GP 3 times or 4 times, and yes, they've been reassured that you can't get Crohn's disease. She's only 3, she's only 4, she's only 6. So young children having even longer periods of symptoms than older children because it's not being thought about or not being recognised. Surprisingly, also, the children that had a sibling with inflammatory bowel disease also had a longer period of symptoms before they were diagnosed than average. And we're not quite sure of the reason for that, but as many of you may be aware, Crohn's disease, ulcerative colitis can certainly run in families. So just pausing on our Madonna again, just to remind you in terms of what children should look like. And again, just reminding you about the gut. That flower's still there. So children tend to have very different patterns of inflammatory bowel disease than adults. And this is some data from Scotland. And this looks at 400 odd children that were diagnosed with Crohn's disease, and I think it was 300 odd adults, so a few less. And this looks at their patterns of what parts of the gut were involved. This looks at the small bowel, this looks just at the large bowel, this looks at the small and large bowel being involved together, and this looks at the stomach, the esophagus, the duodenum, those upper parts. So there's some differences between less small bowel by itself in children, less just colonic disease, more involving the small and the large bowel together, but a huge difference in terms of the number of children and adolescents that have changes in the stomach or the small bowel or even the esophagus, so the parts up above. So 2/3 of the children in this group. And similarly with ulcerative colitis, we mentioned these sort of groupings before, so the lower part, the proctitis, the left-sided part, and pancolitis. You'll see again some children and some adults. Most of the children, almost 3/4, had pancolonic disease involving the whole of the colon. Very few, just that last little bit, and some having left-sided disease. And these children here, at the beginning, very quickly, by 2 years in this study, progressed to having the whole of the colon involved. So big differences in terms of the patterns of disease between children and adults. Again, reiterating that children aren't just little adults. Their patterns of Crohn's and colitis are different. And then generally in children having much more extensive disease, involving more of the bowel, and sometimes meaning it's harder to control or having more complications and so on. Just to follow up on this upper gut part again. So this is a study that we did. So 86 children, newly diagnosed, 55 of them had Crohn's disease, and all of them had scopes at the top and scopes at the bottom. 50% of the time we could see something in the upper gut. And 9 of them were diagnosed just on the changes in the upper gut. Their colon was completely normal. And if they'd just had a colonoscopy, they would have been dismissed as not having inflammatory bowel disease. And in 13 of them, we're able to decide between is it Crohn's disease or is it ulcerative colitis based upon changes in the stomach or the duodenum or other things. So it happens a lot in children in terms of that part being involved, and looking at that part is really important in terms of getting the right diagnosis and making the right choices in terms of treatment from there. So no matter which way you look at it, whether you're upside down or the right way up, growing is really, really important, and nutrition's really, really important in children, especially with inflammatory bowel disease. Almost all children in this study, 85% of children with Crohn's disease, had a history of weight loss before they were diagnosed, and 2/3 of those with ulcerative colitis lost weight. So it's very, very common. And this is particularly the reason. They might get sore, they might get queasy, they might get full more quickly, but they don't want to eat as much. And if you're not eating as much, you haven't got as much fuel to maintain your growth, and you'll lose weight. There may be some malabsorption, they're fighting inflammation, so they're using energy the wrong way, but it's particularly the decreased intake. And if you're not gaining weight, that can lead to not gaining height. And remembering those graphs around 12, 13, 14 is a really important time in adolescence because it's when you're going into puberty. And if you're not gaining weight, you're not getting taller, you may also not be going into puberty at the right time, and that can lead to all sorts of other things. These problems in terms of linear growth, height gains, and puberty are much more common in Crohn's disease and ulcerative colitis. It's especially during this early adolescent phase, and it's more common in boys than in girls in terms of being a problem. And for those of you that have boys and girls, you'll know that boys tend to start their puberty a little bit later than girls, and it tends to go on a little bit longer, so there's more time for their Crohn's disease to interfere with that process, if you like. How does this happen? One of the key things is that there's less of this guy here. IGF-1, or insulin-like growth factor 1, is made in the liver, and it's a really important protein in terms of growth hormone. So growth hormone, made up here at the bottom of the brain, signals through IGF-1, so it needs the IGF-1 to be able to get the optimal benefits from the growth hormone. IL-6 and TNF-alpha are two of the proteins, two of the cytokines that are made in the inflamed gut. They spill around in the bloodstream and they affect all sorts of things, but they suppress bone growth, they suppress the production of IGF-1, and they're also part of that process in terms of feeling full more quickly. They're anorexic hormones, if you like. They make you not want to eat. In children that have known Crohn's disease, steroids may also be another factor that interferes with height gain, and which we'll talk about in a minute, but generally one would want to avoid steroids at all costs. So what are we going to do when someone's diagnosed with inflammatory bowel disease? So some of the key things are that children with inflammatory bowel disease should be recognised as children, being seen in a paediatric setting, having a child and family focused approach, multidisciplinary involvement in terms of the different aspects that might be important, and catering to all those aspects. So we can focus upon decreasing inflammation and helping symptoms. We can avoid treatment-related complications, remembering that someone who was diagnosed when they're 12 has got 70 years in front of them of their Crohn's disease. So it's not just focusing upon the now, but also the future as well. We also want to make sure these other things happen, optimising growth, normalising pubertal development, and ensuring social development. Making sure that kids with Crohn's disease can get to soccer, can get to making sure they're getting to school, making sure they're having sleepovers, and all those other things that kids need to be doing and want to be doing. We can distill that down to this very simple equation. Growth equals the success of therapy. If a child with Crohn's disease isn't growing properly in terms of gaining weight or not gaining height or not getting into puberty, then that likely suggests that their therapy isn't successful and that something should be changed. Also the concept in terms of getting control and keeping control, and we'll talk about that in terms of the therapies in a minute. Getting control of the inflammation, getting into remission, then keeping control, staying in remission, preventing relapses. And many children will need to have ongoing medications and may well need to have more than one medication, and that's particularly reflecting the extent and the severity of the disease that we see in many children and adolescents. As I've said, in terms of the patterns, many children have big areas of the gut that are involved. So what can we do in terms of the therapies? So we can use these sort of things to get into remission, and this is just a selection, if you like. On the menu tonight we have, so we could use enteral feeds, exclusive enteral nutrition, where we're using a nutrition approach, and I'll touch a little bit more on that. We could use steroids, and nowadays this would be very much the minority that would be given steroids at the beginning. Salicylates or aminosalicylic acids, so pentasa or relatives, and for ulcerative colitis that might have a role in terms of inducing remission, probably not in children with Crohn's disease. Several antibiotics may have a role, probably as much for their anti-inflammatory benefits as their antibiotic effect. In children with very severe disease, so other drugs may need to be needed to induce remission. And tacrolimus or cyclosporin are two examples. And then there's the biologics, infliximab and adalimumab, that might be needed to get things under control. In some children, it might be an operation to take out the part that's inflamed, that's not responding to medical therapy, or to take out the part that's causing a complication. That might be the only way to induce remission in some children early on. And there's other therapies as well that tend to be less utilised because they don't work so well. And then on the other phase, maintaining some ongoing drinks, maintaining some ongoing enteral nutrition can be important. The aminosalicylic acid, the pentasa, the sulfasalazine and relatives may have a role, particularly in ulcerative colitis. Again, less so in Crohn's disease. And then it's these immunomodulators, azathioprine, 6-MP, that work on one pathway, methotrexate, which works in a different way, and probably 2/3 to 3/4 of kids, particularly those with Crohn's disease, require this sort of medication and often require it soon after diagnosis. Then there's the biologics. So if you've got interremission with infliximab, then one can maintain remission with infliximab. So exclusive enteral nutrition, just to mention that a little bit more. So this is something that's been around from the early 80s. It was an Irish study initially in adults that used a special formula and compared that to adults being given steroids. And they showed very similar results in both groups. Subsequently, the type of formula has been looked at, and polymeric formulas, so whole protein formulas, are just as effective as using special formulas. Generally, the concept is that this needs to be exclusive, so it's just having that drink, not having normal eating and drinking. And there's one study from England 10 years ago that showed that. In children, generally children and adolescents, generally the response is the same as the response to steroids. So about 85% of the time will go into remission. It seems that it works much better just after diagnosis rather than 2 years down the track or 5 years down the track in terms of the response rates. And it seems that it works better in children and adolescents rather than in adults. And it's not quite clear why that is. It may reflect that children have a parent or a parents to help maintain and cope with just having drinks. Because it is a change from having breakfast, lunch and dinner to having just drinks. A standard protocol, so using the special formulas for 6 or 8 weeks, just having the formula, not having normal eating and drinking, working out the volume based on the energy requirements. In most children it's given orally, some might need a nasogastric tube, and they require lots of support, regular review, adjustment of the intake. So one boy that was diagnosed 3.5 weeks ago, who was 20.1 kilograms when he was diagnosed, I heard on Thursday he was 25 kilograms. His blood markers have already improved dramatically. He's back at school. He's wanting to get back to play soccer and so on. So even just with just over 3 weeks of his course of treatment. Generally about 80 or 85% enter remission when you're newly diagnosed, and some studies have suggested about 60% when you've had other therapies and it's being used subsequently. After that initial course, one can help to maintain remission, sometimes by using oral supplements. There's one Canadian group that have looked at giving overnight feeds for 3 or 5 nights a week in addition to normal eating, and that kept people well. And there's a group from Montreal in Canada that gave 1 month of this, 3 months of normal eating, 1 month of this, 3 months of normal eating. And they also proved that you can maintain remission in that way. I tend to do it this way in terms of giving ongoing supplements in addition to normal eating. And that for some kids can be all they need to maintain them and to keep them in remission. One of the key things in terms of treating inflammatory bowel disease, whether you're a child or an adult, is getting this concept of what's called mucosal healing, where those ulcers that we saw before are healed, where those ulcers, wherever they are gone and the bowel's back to where it should be if you look at it through the scope test. And EN is very good at getting healing of the bowel. This is an Italian study where they gave a group of children drinks and another group of children steroids, and they repeated the colonoscope after 10 weeks and looked to see how many had got healing at that point. And those that had drinks, 3/4 of them had complete healing of their ulcers and of the other changes on the surface after 10 weeks. And only 1/3 of those that were treated with steroids had healing of their ulcers. So they were feeling better and so on with the steroids, but they weren't healing on the inside. And there's a study from Brisbane that's just been published showing very similar changes, that you get very good healing of ulcers, not just in the colon, but also in the small bowel. And they looked at MRI to look at the small bowel and repeating the colonoscope. But it also does lots of other things as well. This is looking at bone turnover. And many of you will know that bone health is important and that bone health can be disrupted by bad nutrition, by the inflammation, and sometimes also by medicines such as steroids. And this looks at what happens with children that were given that nutritional treatment and looking at markers of bone turnover. This particular graph, which is black, this is at the beginning, and this is a marker of bone breakdown. So the children were having lots of turnover of their bones at the time they were diagnosed, spilling lots of this protein into the bloodstream, and after 6 or 8 weeks, this had come right down to here, which is exactly the same level as a group of control children without inflammatory bowel disease. In addition, markers of bone formation increased back to where they should be compared to some control children. So the bone turnover changes dramatically, even over that 6 to 8 weeks. And what happens longer term? So this is one study looking at what happens over a 24-month period after having those drinks at the beginning compared to children that had steroids at the beginning. At 6 months, their disease activity is lower. They have substantially less steroid exposure over those 24 months. So once you've had one course of steroids, the tendency has been to have another course of steroids if you need to. And these children treated nutritionally also had much better height gains. So they were feeling better, less steroids, and they grew better. And many of them also did not have a flare over that time. So this looks at this is at the beginning, this is the steroid line, this is the nutrition line. By 24 months, all the children that are treated with steroids at the beginning had had a relapse. But 40% of those that were treated with nutrition at the beginning had not had a relapse over that 24-month period. Substantially less relapses in that group. So how could this work? How could just having a drink work? There's a number of, this is important because it might mean that you can optimize the way you give the drinks or how you give the drinks or what sort of drinks you give. And it may also help us to understand more about why people get inflammatory bowel disease. If we can understand how this switches off something, maybe it'll help to tell us how that gets switched on at the beginning. And there's a number of important things, and there's a number of studies looking at these aspects. There's direct anti-inflammatory effects, so it changes inflammation on lining cells in the gut. It changes the flora, those bugs that we talked about before, it changes them substantially, not just during the period of the drinks, but also for a substantial period afterwards. And it also makes the lining cells in the gut much stronger. Barrier function is how well those little cells stick together and how well they stop things sneaking between the cells. This nutritional treatment makes that barrier stronger, makes the connections between the cells, the so-called tight junctions, much stronger. Which of those is most important isn't clear at this point. My money's on the barrier function, and there's lots of ongoing work looking at different aspects of how this new treatment exerts its benefits. In terms of EEN, in terms of exclusive enteral nutrition, it's well validated and it's safe, high rates of mucosal healing, and there's multiple mechanisms, including the normalisation of barrier function. And I'm just going to touch on biologic therapies for a minute as well, and some of you may well be acquainted with infliximab or Humira, adalimumab, but as we understand more about the immune system, that's led over the last 10 to 15 years with a whole range of new therapies that are focused upon different aspects of the immune system or the inflammatory pathways. And infliximab is the one that's been around the longest. It was the first kid on the block, if you like. So more than 1 million people worldwide, not just for inflammatory bowel disease, but also rheumatoid, joint diseases as well, even a role for asthma and a whole lot of other things as well. So given for 3 doses in the first 6 weeks, and then given every 8 weeks if it's working and it's maintaining things. This is what it looks like. So it's an antibody. It has a combination in yellow of the human protein and a little bit of mouse protein. And some parents have asked me if their child will like cheese more afterwards because of that, but they don't seem to. So it's a combination of those 2 proteins. It's the antibody. On the far side is adalimumab or Humira, and it's a humanized version of the same antibody. So and so it doesn't have that mouse protein that the infliximab does. And this little cartoon just demonstrates what it does. So these guys floating around, these triplet things, are TNF-alpha. So that's one of those cytokines I mentioned earlier that's really important in terms of driving the inflammation in inflammatory bowel disease. And this is the receptor. So TNF comes along, it binds to the receptor, and it leads to a whole lot of things happening within cells that generates a whole lot of new inflammatory proteins. So if we give some infliximab, we'll give an infusion, it goes around, it binds onto the TNF, whether it's in circulation or whether the TNF is bound to something else, and it stops it getting to its receptor, which means that there's no signal, which means that you don't get that inflammation cascade happening within the cell. So it disrupts things at that point. That's the key mechanism of infliximab. It does a whole lot of other things as well, but that's the key mechanism of infliximab and adalimumab. It does come with side effects, so infusion reactions, increased risk of infection, particularly recrudescence of things like TB. You can get autoantibodies, and you can get antibodies to the antibody. And more recently, there's been concern in terms of increased rates of lymphoma, particularly hepatosplenic T-cell lymphoma. There are other biologic therapies, and natalizumab is one of these, and this is available in the States, for instance. So it's a humanized antibody against a protein on white cells. So it stops the white cells leaving the bloodstream and getting to the gut. And there's a related antibody that's being evaluated, and there's trials in adults in New Zealand that this new protein's being looked at as well as internationally. These guys are part of a wide family, if you like, of biologic therapies, and this is just a selection of those that are working on different aspects of the immune system, of the inflammatory pathways. There are many other therapies that are being looked at as well, and again, this is just a selection of these, and that includes the pig whipworm or the Trichuris suis. It includes other things that are being looked at in different ways or in different levels of developing the evidence to see if they're helpful or not. Okay, so let's just draw us back to Madonna and Child again. Just to reiterate that children aren't just little adults. They're very different, not just in their size, but also in terms of the genes that are involved in Crohn's disease, the location of disease, the patterns of disease, and their response to therapies, and a number of other things that I haven't touched on in detail. The key aspect in terms of managing children with Crohn's disease and ulcerative colitis should be a family-focused team approach. Obviously wanting to get control of inflammation and keep control of inflammation, but there's also all those other goals as well in terms of optimizing growth, normalizing development, getting into puberty and so on. And remembering that if I diagnose a child, I'll look after them during their childhood, but then they'll graduate and move on to the adult sector, and they'll have many decades of their Crohn's disease in front of them. Again, just to put that in a different way, we have inflammatory bowel disease in the centre, but all of these things are really important. So it's not just the treatment, it's their nutrition, it's their quality of life, it's getting to soccer games and it's having sleepovers and so on. It's getting into puberty, making the social development that children and young people need to do. It's how the family's coping, how the other siblings are coping, making sure the children are getting to school, or if they're not getting to school, making sure they're getting to health school or doing something, and making sure they're growing. And all of those things together are really important, and that's why it needs to be a multidisciplinary thing. So the dietitian needs to be involved, the social worker or the psychologist needs to be involved for different aspects. It's not just me, it's the whole team. So I'll just leave you with Thompson and Thompson. They might be pondering something. You may be pondering something as well. I'd like to thank you for your attention. Thank you very much.
Let me thank Andrew on your behalf. First coming down, I think you've given an outstanding presentation. Children are very much, not neglected, but we need to bring children very much into our focus. And it's a growing problem in New Zealand, a real problem. And I do thank you, Andrew, for highlighting that in a very professional way. So would you join me, please, in thanking Andrew for his presentation today.